My name is Nicholas Short from MD Anderson Cancer Center in Houston, Texas. So our chemotherapy-free treatment strategy is an option for patients with Philadelphia chromosome positive ALL. So we'll talk about some of the current strategies that are available for these patients, but I would argue that yes, these are now a viable option for many patients. So historically, patients with Philadelphia chromosome positive ALL, at least those who were reasonably fit, would receive combination intensive chemotherapy, often with a regimen such as hyper-CVAD, in combination with a BCR-ABL tyrosine kinase inhibitor. And so historically, we've used first or second generation tyrosine kinase inhibitors. This would include imatinib, dasatinib, nilotinib, for example. And with these combinations, we can generally achieve long-term survival rates of 35 to 50+%. However, unfortunately, many patients still relapse with these regimens. And these regimens are typically driven by mutations in the ABL1 gene, specifically the T315I mutation, which can be present in up to 75% of patients at relapse. Also, it's notable that when we do treat these patients with intensive chemotherapy, that they, even though I think that we have good supportive care and we can mitigate the risk of morbidity and mortality, there can still be many complications when we give patients intensive chemotherapy, such as infections, and some patients, particularly those older patients treated with these regimens, can even die from complications. So that's an important thing to consider when we're choosing frontline regimens. So there's been many investigators that have looked at lower intensity therapies. So not even necessarily eliminating chemotherapy, but maybe can we reduce the amount of chemotherapy? And certainly there are some viable strategies with lower intensity chemotherapy in combination with a TKI. But still we see long-term survival rates similar to what I discussed before. Some investigators have looked at just TKI plus steroids, so truly chemotherapy-free combinations for these patients. But I think that those have seemed to lack efficacy because they're only getting just basically a TKI with some steroids. And so we see that the response rates, and specifically the molecular response rates achieved with those regimens, are not as high as we would want, and certainly not as high as we get with intensive chemotherapy. So moving forward to kind of the modern era, where now I think that we have very viable chemotherapy-free regimens. So one drug that we know is very effective in Philadelphia chromosome positive ALL is blinatumomab. So blinatumomab is a bispecific CD3/CD19 T-cell engaging antibody. They're shown to be active in patients with relapsed refractory Philadelphia chromosome positive ALL, giving a response rate of about 35% and very high rates of MRD negativity. So it's a very active drug. And so we at MD Anderson and also other investigators, specifically the GMEMA group, the Italian group, have looked at blinatumomab plus TKI combinations in Ph positive ALL. So the D-ALBA study was a group that, again, done by the Italian group, that was a combination of dasatinib and blinatumomab for patients with newly diagnosed Philadelphia chromosome positive ALL. So in that study, patients received 3 months of dasatinib and a steroid, followed then by blinatumomab consolidation. Though with that regimen, they saw relatively high rates of MRD negativity, so molecular response rates of about 60%. And the initial published data, they reported a 1-year survival of 94%, which is very encouraging and for patients with Ph positive ALL, particularly with a chemotherapy-free approach. With longer term follow-up, more recently, they've presented data with a 3-year survival rate of 80%, so showing that there is good durability of these responses. Now, they still transplanted about half of those patients. So the question is, even when we give a chemotherapy-free approach, specifically with dasatinib and blinatumomab, do we still need to do transplant? And again, half of patients receive transplant, so it's not really definitive in terms of who should or maybe should not needs to or does not need to undergo transplant first remission. So one thing that we have done at MD Anderson is look at a similar chemotherapy-free regimen, which is ponatinib and blinatumomab. So ponatinib is a more potent TKI. It's active against those T315I mutations, which are a major mechanism of relapse in patients who are treated with first or second generation TKIs. So it's generally, again, more potent, and so that's why we were very interested in combining it with blinatumomab. We do our combination a bit differently, where as opposed to the D-ALBA study, where they did a lead-in first of dasatinib and steroids, we start the ponatinib together with the blinatumomab right beginning on day 1. So patients receive ponatinib, 30 milligrams initially, and then that's dropped to 15 milligrams once patients achieve a complete molecular response. We also combine it with blinatumomab for up to 5 cycles, and then patients receive ponatinib as maintenance afterwards. As in the D-ALBA study, we give 12 doses of intrathecal chemotherapy. So there's no systemic chemotherapy, but intrathecal chemotherapy is still a very important prophylactic measure for patients with Ph-positive ALL. And so we recently reported our data on this with the ponatinib blinatumomab regimen. We treated 35 patients in the frontline setting. We see very high rates of molecular response. So 85% of patients achieve PCR negativity, which we know is associated with better outcomes. And importantly, we only transplanted 1 of the 35 patients. So the vast majority of patients did not undergo transplant. There have been no relapses, and the estimated 2-year event-free and overall survival rates are both 93%. So it looks to be very encouraging survival data as well, durability of responses, and we're eager to see the longer-term follow-up and also more patients. So I think that the field of treating patients with Ph-positive ALL is really moving toward these chemotherapy-free approaches. We're particularly excited about the ponatinib and blinatumomab, but I think that the data from dasatinib and blinatumomab is also very encouraging. The hope is that when we use even more potent TKIs, such as ponatinib in these combinations, that hopefully we can overcome the need for transplant. And this is very important because historically, transplant was considered standard of care for all patients with Ph-positive ALL. And now we're moving towards regimens that are actually eliminating chemotherapy, which is also an integral part of treatment for these patients, and now also potentially eliminating the need for transplant. So this is really a major paradigm shift in the treatment of patients with Ph-positive ALL. So in sum, I think that these chemotherapy-free approaches, particularly with blinatumomab with a TKI, are really the way of the future in Ph-positive ALL. I think that we have enough data from these 2 studies to show that this is a viable option that can be used in routine clinical practice. And we'll wait for longer-term follow-up, but I think that with very effective regimens like these, assuming patients achieve MRD negativity, I think that we could hopefully avoid transplant for these patients as well. Thank you for your attention.